Hello, everybody. Welcome to Grand Rounds on this Monday afternoon. Delighted to welcome our special guest, Dr. Joshua Richter, who, as you may know, is an associate professor of medicine in hematology and oncology in the myeloma division at the Tisch Cancer Institute at the Icahn School of Medicine at Mount Sinai, and the director of myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai. He has a particular interest in immunotherapy, multifunctional antibodies, and precision medicine, and we're excited to have him talk to us about myeloma today. Dr. Richter, take it away.
All right. Oops, before I'm already messing some things up. Thank you guys so much for having me. The title of the talk today, a little bit of a play on some Charles Dickens. It's a myeloma carol, the story of the past, present, and future of myeloma. Don't worry, there will be no ghost of past, present, future. I was reached out to by your chief residents to talk about, the future of myeloma, and it's kind of one of those like lessons we all learn in AP history. You have to know where you were from to know where you're going. So let's kick things off. And understanding that malignancies, some malignancies are a repercussion of modern day life, things that we eat, drink, smoke, encounter. Myeloma is an ancient disease, and it's actually been documented on some imaging of sarcophagi from some of the great kings of Egypt that were known to actually have died from myeloma. So this disease does date back quite a bit of time, but our first understanding of this as a disease really didn't come to the 1840s, and this is really where things all got started. It was a letter from Dr. William McIntyre to Henry Bench-Jones. And for those of you who kind of know a little bit about myeloma, Bench-Jones protein is really what we call the myeloma protein in the urine. And this really all started when he sent the letter saying, "Dear Dr. Jones," no, not Indiana Jones, although I do hear they're working on yet another movie. He was looking at the urine of a patient of his, and he kind of divulges into this. It contains urine of high specific gravity. It boils, it becomes opaque, it effervesces, heat liquefies it. What is it? And this correspondence that was published, over 150 years ago, really started our understanding of what this disease is. Now, the first person to ever be officially diagnosed with myeloma was a young woman by the name of Sarah Newberry. Now, Sarah was in her late 30s. She was diagnosed in the 1840s, and therapy back then was much, much different than it is today. Nowadays we talk about Revlimid and daratumumab and antibodies and CAR-Ts. Her induction therapy was rhubarb and orange peel. Now, it may not be a shock that rhubarb and orange peel didn't really do too much for her. She went on to her second line therapy, which was steel and quinine. Also didn't really do a whole lot. And in her final days on this earth, she was actually given the latest and greatest of her day. And in the late 1840s, the greatest medical advent was leeches and bloodletting. And I try to imagine an end-stage myeloma patient who probably already had a hemoglobin of 6 or 7 was then given leeches. And it really was, a horrible thing. And one day I'm hoping we look back to what we do today, even with our successes, and laugh at it. Now, it took a long time until we actually had real clinical studies, real medical evidence-based medicine of how to approach myeloma. And the first randomized placebo-controlled study in myeloma was published in Blood in the 1960s. So we're going this down, 1966 to be exact. And this was a head-to-head study of urethane, yes, urethane, the stuff that's underneath your floors, compared against a syrupy placebo drink, which was pretty much like flat Coca-Cola. And this was a legitimate study. It's published in Blood, head to head. And yes, Coca-Cola or flat Coke did slightly outperform urethane, wood solvents. So, again, as silly as this was the path that we took to start understanding that in medicine, you can't just give something. You have to establish a standard of care. We compare against a standard of care, and we slowly improve upon that. So how do we kind of progress from cola to cure? We look at the progress that we made. And the SEER website is really great at giving us a hint into where we've come and where we're going. And if you look back to the 1970s, In the 1970s, the entire journey from diagnosis to death for a myeloma patient was 2 years. Doesn't matter if you're old, young, fit, frail, rich, poor, 2 years was the median overall survival. And now we're looking at 5-year survival rates of almost 60%. And newly diagnosed patients with standard risk disease diagnosed in 2023 are going to live over a decade, if not decades. So we've really come a very far way from the 1970s. So we only have to look at what our most recent data is for what we talk about with newly diagnosed patients. And again, nowadays, we still talk about stem cell transplant, autologous stem cell transplant. But whether or not you're doing that or not, the outcomes are still amazing. So here is our recent data about what we do in transplant eligible patients. And we're talking about overall response rates that are butting up against 100%, with progression-free survivals that we're measuring in 3, 4, 5, and 6 years, not as a total journey, but our progression-free survival for our first-line therapies. So young and fit patients with the latest and greatest in the US are probably getting on whole about 5 to 7 years average from the upfront therapy. Even if you're not eligible for transplant. If you're not eligible, you're older and frailer, we still have regimens that are getting us up to 93% response rate from the MAIA study. And MAIA study is a combination of daratumumab, a CD38 monoclonal antibody, and lenalidomide, a derivative of thalidomide. If we give that to the transplant ineligible people, the median progression-free survival, and we're not even at there yet, we haven't reached it, is greater than 60 months. Meaning, in the 1970s, if you were newly diagnosed, healthy, fit, no medical problems, the entire journey from diagnosis to death was 2 years. Now, if you're in your 80s or 90s, your first-line therapy is going to get you more than 5 to 6 years, a real far cry from how far we were back in the 70s. Now, again, stem cell transplant is still part of our core approach in younger, fitter patients. And if you look at the Griffin data, and this is really established as the new standard in multiple myeloma. This is your average patient that we diagnose. We give a 4-drug or a quad combination of daratumumab, the CD38 antibody, dexamethasone, the steroid, lenalidomide, which is the derivative of thalidomide, and bortezomib or Velcade, a proteasome inhibitor. We are getting 100% response rates. So again, sitting down with a newly diagnosed cancer patient and saying, what we're going to do next works 100% of the time is an amazing achievement and a pleasure to be able to provide in the clinic. And if you look at, on the right, if you look at some of these response rates and survival rates, they're unbelievable. And those are pretty flat curves now at 4-year overall survival rates with a quad combination of 93%. So really, newly diagnosed patients are doing absolutely amazing on the whole, and we expect their survival not to be measured in months or even years, but some of them even decades. Now, what happens when the disease relapses? Because unfortunately, we see more and more relapse. And to really sit down and go through the hundreds of trials is not going to be helpful. But I really just kind of want to lay the landscape of where we're at the moment when the disease comes back. And when the disease comes back, for the most part, in the early setting, we're using variations on a theme. Instead of giving one thalidomide analog like Revlimid, we may use pomalidomide. Instead of using one proteasome inhibitor like Velcade, we may use carfilzomib. Instead of one CD38 like daratumumab, we use isatuximab. And these studies here are, for the most part, just second and third generation drugs of the same class of agents. And we see progression-free survival rates here ranging from around 11 months all the way up to around 30 to 40 months. If you look all the way to the right, those not reached, I apologize, this has been updated at recent meetings. And when you combine carfilzomib, which is a second-generation proteasome inhibitor, with an anti-CD38 antibody, our responses are really measured in the 30-plus month rate. So again, you take about a 5 to 7 year up front, you add around a 3-year second remission, and again, patients can get multiple lines of therapy, and pretty soon you have your decade of response for most patients. But again, there are still people relapsing after that, and there are people with high-risk disease that aren't even doing that well, that we need to look for the next generation. So where we've been in the last 5 to 10 years has been staunchly in the 3 core classes of drugs for myeloma, the holy trinity of myeloma therapy, which has been thalidomide analogs, thalidomide, lenalidomide, and pomalidomide, proteasome inhibitors, bortezomib, carfilzomib, ixazomib, and CD38 monoclonal antibodies, daratumumab and isatuximab. And for the most part, our front line gives some of these, our second line gives others, and third line gives what's left. And that's been the core of our approach for the last decade. But now we're moving beyond that, because number one, that cures almost nobody, and everyone relapses, and some people relapse very quickly. So we're starting to understand the new agents that we're really looking for towards the future. Now, some of these are already approved, drugs like selinexor, a selective inhibitor of nuclear export. That's already approved in people who've gone beyond these 3. And drugs like venetoclax can be used. But really what we're looking towards in the next generation is the T-cell redirection therapy. Basically doing something to take your T cells that are fighting off bacteria, viruses, and not enough of them are fighting the cancer, and taking them and redirecting them towards attacking the cancer. And this is mostly coming in the realm of CAR T therapies and bispecific antibodies. And coming up down along with that is the kind of next generation of thalidomide analogs that are even more potent, iberdomide and mezigdomide, which we'll talk about as well. So what do we do when you become refractory to those 3 classes, IMIDs or derivatives of thalidomide, proteasome inhibitors, and monoclonal antibodies? How are we doing right now? Not well at all. If you look at the progression-free survival here, the second to the bottom row, when you get beyond those 3 drugs, the median progression-free survivals are measured in a handful of months, with overall survivals barely eking out a year for most patients. So this is a huge unmet need that we're starting to chip away at. But again, to quote Sting, we're starting up a brand new day. And this is where T-cell redirection is going to lead the pathway for extremely long durations for some, and for some people, probably a cure. So what are we thinking of when we're thinking of T-cell redirection? Well, basically what we're talking about is using our own immune system, harnessing our effector cells to attack the myeloma. In a day gone by, we used to use allogeneic transplant, noticing that in a normal state of things, our immune system fights off the cancer. But when the cancer gets too big, if you bring in somebody else's immune system, that can fight off the cancer. The problem is allogeneic transplant in myeloma carries with it a minimum of a 10 to 20% mortality rate, which is not quite acceptable. So the new gestalt is saying, what if we can harness the patient's own immune system to work better? And we can harness NK cells, T cells, macrophages, and we have a litany of targets both on the cancer cells and on the effector cells, and trying to find the right combinations to get them together. Now, we're going about this in a large number of ways. Now, we can go about this in the standard antibody approach. You generate an antibody that attacks something that's on the cancer cell, an antigen, and you try to kill it directly that way. Or you can bring 2 cells together. Or we talk a lot about in cancer about immune checkpoint blockade. Essentially, our body makes T cells and immune cells all the time and has a natural checkpoint on it, because if you let that system go wild, that's what autoimmune disease is. But sometimes in cancer, you want the porridge not just right, you want it a little bit hotter. And the way to do that is to remove that immune checkpoint. Or a better way of thinking about it, if you're on the highway driving a car and I tell you to go faster, the answer is not step on the gas, it's easier foot off the brake. And maybe trying to find a better sweet spot where our immune system doesn't go full blast into autoimmunity, but settles a little bit higher level to fight off the cancer. So, really what's the archetype of this is CAR T cells, chimeric antigen receptor T cells. And this has been an amazing technology, which is already FDA approved in leukemia, lymphoma, and now we have 2 FDA approved CAR T cells in myeloma. Now, although this has been fairly recent, the concept of CAR Ts dates back almost 30 years to the original generations of this concept. The notion that we can pherese off someone's T cells. We can engineer them in the lab to all attack a specific antigen. In the case of myeloma, right now, we're all targeting them to attack BCMA or B cell maturation antigen. And then we can give them back to the patient to fight off the cancer. And here's a little concept of how it works. We take the T cells, we use viral DNA insertion that now expresses the antigen receptor, and then it goes and attacks the tumor cells. And this is really almost the revolutionary way of attacking cancer. And although this is approved in these three fields, we are now evaluating this in solid tumors as well. Now, really the data from this comes originally from the KARMA study. Now, this is pretty much what we talked about. We leukapherese or collect these T cells. We give you bridging therapy, basically to hold the myeloma under control while we manufacture the T cells, because right now it takes standardly about 4 to 8 weeks to manufacture the T cells. Now, we can't just infuse them into you because that would be a voice among the crowd. We need to create immunologic space. How do we do that? With lymphodepleting chemotherapy. So right now, even if we pherese off your T cells and engineer them, you still have a diverse T cell repertoire. So you want to create that space. You basically turn the patient into an AIDS patient. You give them fludarabine and cyclophosphamide to clear out their endogenous T cells. And then we infuse the engineered T cells as the dominant force to attack the myeloma. Now, in a space where, as you saw previously, the patients who were refractory to the 3 prior lines had a median response rate of around 20 to 30%, a median progression-free survival of around 3 to 6 months, and a median overall survival of less than a year, here we start to see ide-cel, which at cellular doses of 450 is giving us an 82% response rate. And when we look at responders, if you don't get a good response, a partial remission or worse, which means only 50% reduction of the myeloma, you do dismally. But for those who achieve a complete response, your median progression-free survival is up around 20 months, a far cry from the 3 to 6 months of our standard therapies. Now, what happens about side effects? Well, if you're infusing a T cell, the first thing it's going to do is start to engage that antigen and recruit other T cells and expand, and it releases cytokines, IL-1, IL-6, TNF-alpha, TGF-beta, IL-10, IL-8. They all go up through the roof, and you can develop cytokine release syndrome, which is the main toxicity of any T cell redirecting therapy. CRS is associated with high fevers, tachycardia, hypoxia, hypotension, and can look very much like an infection. So we have to kind of figure out from a clinical standpoint and timing standpoint, if you have a cancer patient who shows up in the ER, hypotensive, tachycardic, febrile, the answer here is not cefepime and vanc, or as Mount Sinai calls it, vancomycin. The answer is therapy to lower the cytokine levels to quiet down the CRS. In general, our first approach is to give tocilizumab, an anti-IL-6 antibody. Now, what happens when those activated T cells cross the blood-brain barrier? Well, you can get something called Icahns, immune effector cell neurotoxicity syndrome. And those activated T cells can actually go up into the brain and cause anything from a little bit of headache and confusion to coma, seizure, and even progress to things like Parkinson's disease. And this is another modality we need to watch out for when altering our T cells. The CARTITUDE-1 study looked at a slightly different construct of CAR T. Same scenario, patients who would progress beyond those 3 prior lines, but this was a slightly different engineered product. And again, these were patients who had 6 prior lines of therapy. They're refractory to everything. But here we saw a 97.9% response rate when we gave this. The median time to first response is a month. So again, we're having patients respond very quickly, which is crucial because if you're refractory to that many drugs, your disease may be blasting off. We need something that's going to work very quickly. The median duration of response to this therapy is 2 years. Median progression-free survival of 24 months. We're really getting amazing responses in a heavily refractory group of patients. And again, some of our overall survival metrics are not even reached. So in a heavily relapsed patient, we are changing the paradigm of what we can do for them. Now, this is a more effective product, at least on the surface. Now, there are some differences in the trial components between this and the previous one. There were fewer patients that maintained disease control during that bridging time, and there was more extramedullary disease outside the marrow in the KARMA study, which is why some of those response rates are lower. But the toxicity here does seem to be a little more pronounced, higher levels of CRS, higher levels of Icahns, and what we call MNTs, these motor neuron issues that can cause a Parkinsonism-like disease. Now, what happens when we start to actually compare what happens to a patient directly, at least a matched, adjusted, indirect comparison between patients in later stage myeloma who get standard therapy versus CAR T? And slide after slide, you're going to do way better in the heavily relapsed setting if we get a CAR T as opposed to a standard therapy. How much better? Well, the overall response rate in the real world analytics is showing about a 32% response rate, 76% if you get a CAR T. Median progression-free survival, again, here, this is real world data, 3.5 months versus 11.3 months, but we're starting to figure out ways to optimize CAR Ts even better to improve that even more. Now, what we're starting to say is, anytime you give any therapy in myeloma, the later on you give it, the worse the response. The earlier on you give it, the better response. So what happens when we take CAR T-cell therapy and moving it up to an early relapse, not a late relapse? And this data was recently presented. Again, this is CILTA-CEL, also called Carvykti, giving to patients with early relapse. It has a 100% response rate. And again, the data is early, but so far these remissions are extremely durable. So, I think what we're starting to understand is that manipulating the immune system in this way, when you start to use it towards the end, you may be dealing with an exhausted T cell. Remember that we're trying to collect T cells and engineer them. But what does a T cell look like after you've had 10 lines of therapy? It looks like me after being on call over a weekend. It doesn't want to do as much. But, what if you take a well-rested Saturday morning or Monday morning T cell, and that's the idea of early collection of T cells that you may collect a more fit and aggressive T cell that you can then engineer and then get a better response on the back end. So what are we doing to improve this? Well, so far we have the 2 approved CAR T cells, and they're doing amazing. Now, what about alternate manufacturing? So alternate manufacturing, well, what if you're able to manufacture right now instead of 4 to 8 weeks? There's the fast CAR out of China that gets manufactured in 24 to 36 hours. Again, if you have a patient whose disease is taking off and you can give them this therapy in a week as opposed to 2 months, you may get better outcomes. What about adjusting the target, the antigen, the engaging, the epitope? All of this may lead to better responses. What about allo CARs? So the Allo 715 trial is saying, well, auto CARs are great, but they still need to be manufactured. What if you had an allo CAR ready to go in your cellular infusion lab that you can literally say, oh, you're progressing today, you get lymphodepletion tomorrow, and then you get the CAR T? That may be the next generation. What about different targets on myeloma cells? Right now, BCMA has been the main target. But when you attack BCMA, you don't just kill myeloma cells, you kill everything else that BCMA is expressed on. BCMA is expressed on early B cells, some mature B cells. So now we're looking towards newer targets like GPRC5D, which is more selectively expressed on plasma cells or really malignant plasma cells, so that we may get fewer off-target effects. And when you don't kill the other B cells, you may have lower rates of infections and other complications. But to me, some of the big areas of interest are really going to be bispecifics. And bispecifics, again, right now they have 2 arms. One grabs onto a target on the myeloma cell, the other grabs onto a target called CD3, which is located on T cells. To me, this is the wave of the future. And this has to do with practice patterns of myeloma in the United States. In the United States, the average hem-onc doc, your average doctor somewhere in the Midwest, sees 0 to 10 cases of myeloma per year. I'm insane, and I see 60 to 100 a week. However, there are way more of them than there are of me. And about 80% of all myeloma in the United States is treated in the community. The community is not able to give CAR Ts. They don't have cellular infusion. They don't have the expertise. It's something that is not going to make it there so quickly. If you think about auto transplants, despite the fact that it's a standard in the US, only 30% of transplant eligible patients get a transplant in the US for a lot of reasons, including lack of access to a transplant center. CAR Ts are more complicated. So how can we bring immune therapy to the masses and make sure that if you're in New York, you can take a rock and you can hit a major medical center? There are places in the country you have to drive 3 to 6 hours to get to one. What about bringing immunotherapy to your average hem-onc doc or two-person practice down the block? And that's where bispecifics come in. And there's a number of targets that are really coming in as being major ones: BCMA, GPRC5D, and FcRH5. So right now, BCMA bispecifics have been the real windfall, and so far we already have one approved. Teclistamab, the BCMA CD3 bispecific, was approved by the FDA this past year. It is available in the clinic. Elranatamab was filed for FDA approval a week and a half ago. We're hoping to see that within the next 6 months. And these other therapies are also available. And again, response rates for most of the bispecifics in heavily pretreated patients are ranging from 60 to 80%. So teclistamab was the first of these, and it was approved at the end of last year based off of the Majestic-1 study. And here's the data for that. And again, this is a diagram in the middle of the drug. The bispecific antibody engages the myeloma cell. It engages and activates the CD3 positive T cell and leads to local cell kill. An extremely effective drug, response rates of around 63%. And as you can see with the swimmer's plot on the left, most of these, if you look right now, about 70% of patients in the original trial are well beyond a year still in remission with their progression-free survival, much better than our standard therapies. Elranatamab is a similarly constructed BCMA bispecific. Again, this was filed for FDA approval about a week and a half ago. Same concept. And again, we're also seeing response rates here of around 64% and patients staying in remission well over a year. Now, because these drugs can also induce cytokine release syndrome, the way that we mitigate it is by doing step-up dosing. You give a little bit of the drug, and a week later you give a little bit more of the drug. And right now, teclistamab involves patients being admitted to the hospital for 7 to 10 days during the step-up period and management of CRS. Elranatamab is shortening it to about 5 days and doesn't even need a step-up dose. But again, here we see patients on the Kaplan-Meier curve from MagnetisM-1, median duration of remission of 17 months. So whereas CAR T is a one and done, you get your CAR T and you're off therapy after that. Bispecifics at the moment, you continue them as long as you tolerate it and as long as it stays in remission. And again, we can treat people here so far in MagnetisM-1, median duration of response, 17 months. And again, same types of toxicities. We see hematologic side effects. We see a number of CRS and Icahn events. The other big issue is infections. So when we're treating patients, remember, one of the consequences of redirecting T cells is that now nobody's minding the shop. Your T cells that were ready to fight off viruses, bacteria, fungus are now over here fighting the myeloma. So it has become a major issue as we're able to control people with these drugs very well, but we're starting to have a lot of later complications of viral, bacterial, and fungal infections, and are seeking ways to better offset this risk. Much of this is coming in the way of giving supplemental intravenous immune globulin. And the other thing that's back on the rise is pneumocystis pneumonia. In the old days, when the only thing we had to treat myeloma was dexamethasone, most patients were treated with what we call pulse dex, 40 milligrams of dexamethasone, 4 days on, 4 days off, 4 days on, 4 days off, et cetera. Once we started having our newer agents, we stopped doing that, and the rates of PCP dropped. Now that we're redirecting T cells, again, making patients functional AIDS patients, PJP rates are back on the rise, and we're starting to have to prophylax patients all over again. Now, what happens when we start combining these bispecific antibodies with some of our other myeloma drugs? And this is data that was just presented a few months ago from the Majestic-2 study, where we take teclistamab, the already approved BCMA bispecific, and start combining it with drugs like lenalidomide and daratumumab. Well, now your overall response rate is jumping up to 93%, with over 90% of patients getting a VGPR or better. That means a 90% reduction in their myeloma or more. Again, the problem is now you're knocking out any cell with BCMA, you're knocking out any cell that expresses CD38, and infection rates are through the roof. So as our response rates are climbing higher and higher, we need to continue to find ways to optimize patients from an infectious prophylaxis standpoint. How do you sequence all of this? There's so much to do. Can you sequence these therapies? Most of the studies didn't allow a lot of prior T-cell redirection, but some of them did. And we note that although you still can eke out responses, your responses are muted when you sequence BCMA therapies. For example, in elranatamab, the overall response rate was 54% with a prior BCMA. If we look at some of our internal data, this is still better than any other therapy. So if you have a patient that's refractory to everything, the best thing to do is to give them a T-cell redirection. If they progress beyond that, if you give them another T-cell redirection, they're not going to be as good as that first one, but it's still better than anything else we have to offer at the moment. What about the non-BCMA targeted bispecifics? Well, there are three main ones, and one of them is a bit far behind. The first one is talquetamab. Now, talquetamab was also filed for FDA approval at the end of last year, and we're expecting talquetamab to be approved in either Q2 or Q3 of this year. This is a GPRC5D CD3 bispecific. Furimtamig is an earlier phase GPRC bispecific. It's a bit farther behind, only in phase 1 data. The other target is FcRH5, another ubiquitously expressed antigen on plasma cells. This drug is a little further behind than talquetamab, but we're likely to see approval in 2024 or 2025. The benefit here is that BCMA as a target is a problematic issue from an infectious standpoint. So trying to find a more specific target to minimize other immune cell killing is to our advantage. So talquetamab, and the sentinel work was actually done here at Sinai with a New England Journal of Medicine article published by Dr. Ajay Chari as the first author, was really leading the way in the non-BCMA targeting bispecifics. Again, response rates here were extremely high, 70, even 80% in some of the cohorts. And again, infectious rates are a bit lower. The one complication is GPRC5D, although not expressed in a lot of other immune cells, has other expression. It's expressed on the squamous epithelium of the hands and feet, salivary glands, and lining of the GI tract. So the main toxicity of this drug, besides cytopenias and some infections, is a risk of dysgeusia, weight loss, and a desquamating hand and foot rash. The Monumental 1 study is what is really leading to the FDA approval. And here is some of the data looking at what happens in patients who already had T-cell redirection. Again, as opposed to 70, 80%, you're still eking out a 63% response rate and significant durability so far. So really looking for sequential T-cell redirection, potentially with alternating targets as the next generation of myeloma therapy, where you give a BCMA, then a GPRC5D, and an FcRH5, maybe in different orders. Now, again, mechanisms of resistance are not solely related to antigen loss, meaning when you progress on a BCMA bispecific, it's not necessarily that you no longer express BCMA, it's that T cells may be becoming exhausted and we may need to reinvigorate them. So a lot of great work being done there. CEVOSTAMAB is our FcRH5 CD3 bispecific, which we are doing a lot of the work here. Again, FcRH5 is ubiquitously expressed on myeloma cells, a little bit on normal B cells, but not a whole lot. Now, one of the things that we noted is that CRS rates with these therapies can be quite high, 70, 80, 90%. This is what's requiring us to admit patients to the hospital. And part of the reason why, although at Mount Sinai and our system, we are well equipped to admit patients to deal with this. But out in the community, admitting patients for a week to 10 days, not so easy. Giving patients a drug that has a 70 to 90% chance of cytokine release, if they're older and frailer, is not going to be ideal. So what can we do to mitigate this? What about giving prophylactic tocilizumab? So prophylactic IL-6 blockade. And what we saw in this study is we saw a reduction in the CRS rates, dropping from around 91% to 38.7%. Now, two things come to mind. If you're blocking IL-6, number one, are you blocking some of the efficacy? And the short answer is no. Even in this small study, those patients that had prophylactic tocilizumab actually had a higher response rate, probably because they were able to stay on course with their drug a little better. What still remains to be seen is, do you have an increased rate of infections, because IL-6 is part of the prodrome of inflammation that helps fight off infection. And when you blunt that, you may put yourself at risk for further infection. Again, it's a one-time dose of the drug, so it may not be a big concern, but we're still trying to tease that out. The other issue is at the moment, we're giving our bispecifics continuously. You stay on it and you're on it until you don't tolerate it or progress. For teclistamab, the FDA-approved bispecific, the drug is given once a week, every week, no break by the FDA label. That's a harsh thing for patients to literally come in once a week. What if there was a way to rationally stop these drugs and mitigate a risk of relapse? Now, the CEVOSTAMAB trials are designed to give 17 cycles, and since the drug is given every 3 weeks, that pretty much amounts to 1 year of therapy, and then we stop and observe. And if you relapse, you can restart the drug. Now, we have some data that we presented at ASH, and we're going to present at the upcoming COMI meeting, showing that we have a large number of patients that were able to maintain their response. What's really interesting is that anyone who had a stringent complete remission or deeper has not relapsed yet. So maybe we're starting to enter a realm of biologically driven response mechanisms by which we can alter our course of therapy. Meaning, just like in the CAR Ts, if you had a deep response, you did well. If you didn't, you did not do as well. Here, if we're able to deepen your response so much that you achieve a stringent and complete remission, maybe that's enough to stop our bispecifics and not only get you off therapy, but give your T cells a break and a chance to not be completely exhausted. Take a couple breaths and only re-engage them when they need to be engaged so that A, therapy works better, and B, they can go back to minding the shop to prevent other infections. So the wave of the future of bispecifics is going to be fixed duration and probably driven by depth of response. Now, switching gears to some of our other therapies, the new derivatives of thalidomide, also called CELMoDs. Now, CELMoDs is a marketing term. These are all derivatives of thalidomide. So thalidomide, lenalidomide, pomalidomide, and now the 4th and 5th generation, iberdomide and mezigdomide. These studies are ongoing. We're running them here at Sinai. And originally, we're seeing iberdomide here given at different cohort levels as a dose expansion along with dexamethasone. Here, this is showing us pretty much what we're seeing with our standard therapies and late-line therapies, a response rate of around 26% with disease control rates that are not tremendous. And again, when you combine them, yeah, your median progression-free survival here is 13 months, which is pretty good. But what is more important is the future of these therapies is likely to be given in concert with CAR Ts. Because at the moment, we're not curing with CAR Ts, and one of the drawbacks and one of the reasons that people progress after CAR Ts is T cell exhaustion. Well, what do thalidomide analogs do? They upregulated NKT cells. So maybe you give a CAR T to knock people down and you maintain NKT cell activity by giving them a pill like iberdomide. Those studies are ongoing. Now, we're starting to notice that these drugs are overall well tolerated, and iberdomide has actually less myelotoxicity than Revlimid, our standard drug. So there's a push to start moving iberdomide into every place that lenalidomide exists because it seems to have a more potent efficacy and less in the way of lowered blood counts. Now, what happens, of course, we're going to combine this with other therapies. And the big phase 1-2 studies are combining iberdomide with daratumumab and bortezomib. And now we're starting to see response rates get a little bit higher, 40%, 60%. So again, it's really about inventing a drug and then optimizing its use later on. What is looking at the next generation beyond iberdomide is mezigdomide, also called CC92480. This data was just presented at ASH a few months ago by Paul Richardson. Again, these are pills. So when we talk about health-related quality of life, giving these big CAR Ts or immune effector cells, wonderful. But if there's a way to maintain the response with the patient at home taking a pill a day, that's a lot more optimal. And again, now the pill alone is showing response rates of 40 to 50%, including patients who had prior BCMA therapy. So again, this is what happens when we look at the drug towards the end. What happens when we move it further up, or what happens when we take a patient who's not progressing, but in remission from their myeloma, either with a T cell redirecting bispecific or a T cell redirecting CAR T. And instead of continuing to pummel the T cells with more redirection, we just upregulate the whole thing with a cell model. And in our last few minutes, I kind of want to talk about a few other approaches that are really changing the way we approach myeloma. Now, there may be people on the call who remember the days where we used to give interferon for everything. Hopefully, a lot of you are young enough not to have to live through these days, but there was a point in time where for CML, myeloma, Hep C, we were giving interferon. Now, one of the main issues with interferon is that it gives you depression-like symptoms, suicidal ideation, and makes you feel generally awful. However, what happens when you approach this great cell kill from the standpoint of an antibody-drug conjugate? And that's what modakafusp alpha is. You take a CD38 bispecific and you attach an interferon warhead. So as opposed to giving systemic interferon with systemic toxicities, it links onto the CD38 myeloma cell and injects the interferon. And this data was recently presented by Dan Vogel at the 2022 ASH meeting. Now, the response rates here were around 43%, with a bunch of responses in patients with heavily pretreated disease. Now, this may not be as fancy as some of the T cell redirection, but the average myeloma patient in the US is 70 years of age with multiple comorbidities. Not everyone is going to be either have access to or be a candidate for T cell redirection. So this is going to be a nice alternative for some of our patients in the community who don't have the access to some of those more aggressive therapies, because this is not associated with any T cell activation, no CRS, no Icahns. The other thing is the concept of repurposing of some of our other drugs. So it turns out that myeloma, the way we approach it is not from a genomic standpoint. We give the combinations we give because these are highly active therapies. Well, it turns out that myeloma has, when we do deep sequencing or next generation sequencing, we can find a number of what we call actionable mutations. And as we can see here, this is a list of some of the more common mutations, things like KRAS, NRAS, FGFR3, BRAF, PI3 kinase. And the reality is many of these genomic aberrations already have drugs that are FDA approved in other cancers. Many of these RAS mutations are seen in lung and GI malignancies. BRAF mutations are seen in over 90% of melanomas. FGFR3 is seen in GU malignancies, etc. So what happens if we do deep sequencing and we can identify these mutations in a myeloma patient? Well, we can use these drugs that are already approved for other diseases, but use them in the myeloma space. And here's one of our patients who responded amazingly well to this type of therapy. And we're actually doing this from a clinical trial standpoint with the MyDrug protocol, which is being led by the MMRF. We take patients with what we call functional high-risk disease. Well, what does that mean? Well, when we first evaluate a myeloma patient, we look for genetic abnormalities, things like P53 mutations, P53 being the big bad proto-oncogene, and we call them genomically high risk. What a functional high risk is if the standard response to treatment up front is 5 to 6 years, and you relapse in a year, it doesn't matter what your genetics show, you are functionally high risk, you're behaving poorly. We deep sequence these patients, we give them a backbone of a steroid, an IMID, and a proteasome inhibitor, but add on a fourth drug, which specifically targets the actionable mutation in that individual, be it a RAS mutation, RAF mutation, IDH, CDK, to provide a personalized approach. The concept of personalized medicine has been the brass ring of myeloma for generations, and we're starting to do this in the clinic. So this is a patient of ours that we took this approach. This is a patient who had many relapses, and there was nothing left available. We did a deep sequence off of the study and found that they had what we call a canonical V600E BRAF mutation. We took a combination of 3 drugs, dabrafenib, which is a BRAF inhibitor, trametinib, which is a MEK inhibitor, and regorafenib. Now, the reason you have to use multiple drugs is if you remember these pathways back to your first year in medical school, you know, the RAS, RAF, MEK, ERK pathway, if you block one of these, the disease will find an escape pathway around it. So you have to use multi-level blockade to get around the cancer finding escape pathways. But again, in a patient that had no other options, this was a driver mutation of their malignancy. And as you can see, after 3 months, they were in a complete remission. So really leading to personal therapy. So in kind of closing, this is the natural history of myeloma, right? We diagnose patients, we decide to treat them, we go through remission, relapse, remission, relapse. Eventually we get to refractory to our main classes of drugs. And then our general outcomes are dismal. A study called the Mammoth study looked at what happens when you're refractory to our main 5 drugs: Revlimid, Pomalyst, Velcade, Carfilzomib, and daratumumab. When you become refractory to those 5, the so-called pentarefractory, your median overall survival is 5.6 months. Dismal. Absolutely horrible. What does the next generation look like in the next 10 to 20 years? A completely different concept. We've gone through the 3 epochs of myeloma, from the classical chemo days after World War II to the novel agents in the late 90s and early 2000s, and now to the realm of true immunotherapy with T-cell redirection. Our upfront therapies are able to give us a 100% response rate. When we redirect T-cells in the first relapse, we can get a 100% response rate. What if we sequence this properly to get everyone into not only a deep remission, but an extremely deep remission, what we call MRD negative, minimal residual disease negative? That means on bone marrow aspirate, we do not find one cancer cell in 1 to 10 million cells analyzed. Maybe right now we're treating everyone to progression or intolerability that we don't need to. Maybe if you can get them down deep enough, you can stop. And if they have a relapse, you can come in with another T-cell redirection with a reinvigorated T-cell group, combining the concepts of bispecific T-cell engagers, CAR T therapies, antibody drug conjugates, and some of the newer constructs like trispecifics, which engage a myeloma cell, a T-cell, and also have a checkpoint inhibitor to take that break off to make sure we maximize the T-cell efficacy. Those drugs are in trial here at Sinai as well. So we're really looking towards a new realm where when I started doing myeloma, I said, I'm sorry, we don't cure myeloma. It's an incurable disease. When patients come in today, I say, we're curing a small number of patients by accident. We give an 80-year-old these combinations and they die at 90 of a heart attack and never relapsed. They were functionally cured. But the future of myeloma is intentionally curing everyone through manipulation of the immune system in a very intentional way. And with that, I think we're actually coming into a new realm where myeloma in the coming decades will be a curable malignancy. And with that, I will thank you for listening to me and take any and all questions.
Wow, thank you so much, Dr. Richter. What an incredible talk, such a fascinating topic. Thank you for giving this this great lecture. Now I'd like to open it up for questions. I think you already got some chats about halfway through from Dr. Parsa. If I could bring them up here, I could read them out to you. Hi, Dr. Richter, sending this question for the end of the talk. Is there work being done on figuring out whether we should stop therapy for patients who have been on a biospecific for X number of months with no detectable disease? Do you think we should give prophylactic IVIG for the specific patients or treat a decided upon number? Looks like he started to address some of the question while he was typing.
Yeah, so there's a few things. One is the depth of the response, that MRD negative or not. The other is the genetic phenotype. Do you have high risk disease or low risk? And we're starting to understand from some of our trials that good risk disease that gets undetectable, you can probably stop. So far, anytime we try to stop in high risk disease, it comes back more aggressive. And to Dr. Parsa's comment, yes, one of the big toxicities of all of these therapies is hypogammaglobulinemia, now which we can fix with IVIG. The big question is, should we give primary prophylaxis or secondary prophylaxis? Primary being we just give you the IVIG when your immunoglobulins are low, even if you have no infections. Secondary is you have an infection and now we're playing catch up. In general, we mostly give secondary, except now we're starting to give primary in T-cell redirection. So everyone who gets a CAR T gets IVIG until their immunoglobulins are recovered. And we're starting to have conversations about doing something similar with the bispecifics.
Excellent. Okay. Any questions from the audience for Dr. Richter?
Yeah, I got a question.
Sure, sure. Would you like to come up?
Sure, yeah. Hey, Dr. Richter, it's Eddie Drizek.
Hey, how's it going?
I think I was on your service a number of months ago, but just a quick question. Thank you so much for a great talk. I was wondering, so it seems like the biggest problem, kind of like a big picture, is the relapse. At least it's one of the biggest problems. And is there a way for us to actually be able to tell if a patient is more likely to relapse than another patient, and if there's anything else that we can do really to kind of get ahead of that? Maybe like using either CAR T cells or another therapy, another one of the newer approaches to kind of make sure that we can extend that progression or extend that time point until they relapse.
So I'll answer this in two parts, and it's a phenomenal question. One is the therapeutic, the other is the diagnostic. Therapeutic, that trial is starting, which is right now the standard is induction and transplant. But we have a study saying that if we go through all of that and we still have any detectable disease, we have a trial to come in at that point with the CAR T to make sure we do everything we can to prevent a relapse, because we've shown the deeper the remission, the more durable. So if we get you from up here down to there and there's still a little bit left, maybe that's the best time to come with a CAR T. That trial is underway. Now, the other question of a diagnostic one is being done by the Italian group under the helm of Bruno Paiva. Now, we all know that people can have an MGUS, and you can be diagnosed with an MGUS that never progresses. And part of the rationale is, well, there's kind of a two-part to that. Why does it not progress? It doesn't progress because the disease itself is not aggressive and the person's immune system holds it at bay. What happens if, after all of our treatment, there's still some disease, but it has an MGUS-like phenotype, meaning even though it's still there, it's benign stuff that's left, and the immune system is recovered to hold it under control. Bruno is doing this great work to identify these patients that we will never eradicate their disease, but we actually convert them from myeloma to MGUS. And now, if you're a 75-year-old with a low-grade MGUS that's never going to progress, maybe the answer for you is not to keep pummeling this because we'll knock down your good immune system, but maybe your disease is good enough and your immune system is good enough where it's not going to go anywhere. So that's part of the next diagnostic dilemma is maybe you don't need to kill it all, but you just need to kill the bad stuff and let the rest of the immune system recover.
Well, thank you.
Yeah. All right, great questions so far. Let's see, I think we have another chat. Oh, just a thank you from Dr. Rupani. Okay. Any other questions from the audience for Dr. Richter? All right, nothing from in-person audience, and looks like no chats here. So Dr. Richter, thank you so much for your time. Wonderful lecture. Welcome back anytime. We love to have you again in the future.
Thank you so much for having me, and I wish everyone a great rest of your day.
Thank you.